Great. Hi, welcome everyone, and welcome to another session with myself and Dr. Sanjay Mukhopadhyay. We're going to talk about today some small biopsies and approach to small lung core biopsies and immunohistochemistry for them. So maybe before we get into it, Sanjay, do you want to kind of tell people why it's important to think before you just order a bunch of stains on a small biopsy when you're working it for lung cancer?
Yeah, thank you for doing this, Matt. It's a great idea. I think the first uh, issue with immunohistochemistry obviously is, cost and having the patient undergo unnecessary testing. But I think the next issue is when you get a stain that is on a case that is not really indicated, then you have to deal with the consequences of what happens if the stain doesn't do what you expect it to do. So I think you have to think that through before you order the stain. So before you order the stain, you should think, what will I do if it's positive? And what will I do if it's negative? And will it change what I'm already going to do without the stain? So I think that should be your questions to yourself.
Yeah, and I think the other important point too is a lot of these need molecular testing, right?
Yes,
And we
yes,
really don't want to. Sometimes you only have one core that's got lesional tissue, and you can
absolutely.
easily burn through it.
Yes, and especially this is especially true for adenocarcinomas. And I think in that setting, to conserve tissue is super, super important. And that's where you want to minimize immunohistochemistry if you can.
Yeah, great. So what we're going to do is we're going to go through some different scenarios, and I have some little images here for what the biopsy looks like, and then we'll talk about what we do in that case, and some. So we're first going to start on the left side here. So we're going to assume now we have a. I'm going to zoom in on this one here. So we have a core biopsy that's showing some malignant glandular structures here with some intervening fibrosis. So I don't know. What do you think, Sanjay? What would you do in this case? Would you
Gives
well, obviously have Vimentins first, probably, right? What do you think?
first.
Sorry, I couldn't resist. Obviously not a Vimentin first. Please don't do Vimentin first.
No, you've started with the hardest one first, Matt.
Yeah.
So this is the hardest question, and
Yeah.
okay, I'll give you my what I do in real life, right? What I really do with these cases. So I understand that people who don't have any clinical information, like if you're sitting in a small lab with no access to beaker or any clinical information, your clinician doesn't talk to you, you don't have access, there you might be, you're stuck. So you really do need clinical information if you want to do the method that I'm outlining. So you need some clinical information like we have on beaker. So we have all the clinical information that is available to the clinician is also available to me. Second, radiology. So I look up the radiology on all these cases. And so it greatly helps me to minimize immunohistochemistry in this situation. So you need radiology. And third, you need, as you and me, Matt, we do a lot of lung pathology. So we have a good sense of, what is okay morphology for lung and what is not a good morphology for lung. So if we see a colorectal met, it immediately strikes us as something odd, a colorectal met or a renal cell carcinoma. So now, given that background, I'll say in a case that has no history of a carcinoma elsewhere, the radiology is a solitary lung mass, and the morphology is reasonable for lung, like it is in this picture that you've shown. This morphology is very reasonable for a primary lung cancer. In such cases, I don't do any immunohistochemistry and I go straight to molecular. But so now the reverse is also true. If there is a history of cancer, let's say here there was a history of breast cancer or pancreatic or something reasonable that could look like this, I would consider doing immunohistochemistry.
Yeah.
And if there was so for radiology, if this was, diffuse bilateral multiple nodules, I would consider doing some immunohistochemistry, although still you have to ask what immunohistochemistry would you do?
Yeah.
And of course, if morphology was not like this and was like has clear cells or had a morphology like a colorectal met, I would do immunohistochemistry. Otherwise, I don't do it, and all my material goes to molecular testing.
Yeah.
So, Matt, what do you do? I'm curious to know what your practice is.
I'm in a similar situation, so I have access to good clinical histories and radiology, and that really guides a lot what I do. I do tend to do a TTF1 in most cases, more so for documentation than anything. But if the tissue is limited, I don't think I'm at all worried that I'm not going to get molecular, then I'll just do right to molecular. Um, and sometimes I more so do the TTF1 just so if it comes back again somewhere else or some other scenario or someone's got a small little biopsy, we know the TTF1 status of it because and regardless of whether it's positive or negative, it's still the same thing to me. It's an adenocarcinoma.
Yeah,
But
yeah.
yeah, so I completely agree though. This doesn't need a lot of stains. It's completely reasonable to sign it as an adenocarcinoma.
And I think we both can agree that it doesn't need a CK7, CK20,
No,
CDX2, PAX8, GATA3, Vimentin. It,
no,
it doesn't need a huge tray of immunostains. You're just wasting material that could be useful for the patient for targeted therapy.
no, I agree. Okay,
Yeah.
well that's a good discussion. So let's move on. Well, what if it looks kind of mucinous? What if instead of something that looks like just a straightforward acinar adenocarcinoma,
So
but
for me, same thing, Matt. It's the same thing. In fact, here immunohistochemistry is even
yeah,
less likely to be helpful
yeah, I
because
agree.
here TTF is almost never positive in it.
Yeah,
So here's an interesting little tidbit. I've seen when people try to do a TTF1 in these cases, most of them are negative and
yeah,
they often misinterpret them as positive by misinterpreting entrapped lung or a little bit here and there or weak positivity. It's even more useless here than it is in the non-mucinous one like you showed before because most mucinous adenocarcinomas of the lung are TTF negative and they're only, I think, in my experience, rare exceptions to that rule.
yeah.
So I don't. What do you do, Matt, for this
It's
one?
the same thing, and it often gets you in trouble. And the CDX2 is often positive, right? And
Exactly. Exactly.
then it's you kind of just get into a mess. So I think in here the most useful IHC is the clinical history IHC and the PET scan IHC, right? And
Yes, and I think one thing is important to say here, Matt, is like people feel the need to prove a lung primary in every case. And I think the determination of a lung primary is not a purely pathologic job. I mean, it also needs a clinical input. It needs the clinician to make that decision that this doesn't have any, it doesn't have any relevant history. The PET scan is not lighting up anywhere. So I don't feel the need for me to make that fight. So I don't sign out my cases as adenocarcinoma lung primary. I just
yeah.
say adenocarcinoma because that job is a collaborative job between the pathologist and the clinician. And so I don't sign out my cases that way.
And just because it's TTF1 positive doesn't mean it's a lung primary, right?
Absolutely. Could easily be thyroid. It
Yeah,
could easily be many of, one of many other primaries that have been
yeah,
reported to have TTF positivity, including breast and GYN and gallbladder and, a million other things.
yeah. Okay, so moving on. What if now it more has an enteric look? It looks more like colorectal, so have some luminal necrosis, kind of columnar
Yes.
cells with elongated nuclei. What do you
Yeah.
think in this scenario?
So here you can take two, I think you can take two approaches. One is what I do sometimes is if the patient has a history of colorectal cancer,
Yeah,
clinically they're thinking metastatic disease, and the patient has multiple bilateral nodules. Then I think, what is the point of doing any
yeah,
immunosuppression? It is colorectal cancer, and I just sign it out on H&E. Sometimes, I think sometimes I go into a little, anal mode, and I'm a little more. It's a Friday, and I don't want my. I want to sleep at night, so then I'll do a TTF1 and CDX2,
yeah.
and it invariably is CDX2 positive, TTF negative, and I think that it's not at all wrong to do that. If you want to do to confirm, I think this is the setting to do it in.
Yeah.
So both approaches are fine with it.
And I always remember too that you can't have an enteric phenotype of a lung primary, right? So you can have something that looks like this, that's CDX2 positive, but if everything is clinically and imaging supports a lung primary, right? This could be a lung primary,
Correct.
right? So
Correct. I think people who expect that TTF and CDX will solve every lung versus GI question are going to be in for some surprises when they do it on real cases.
yeah, and so I think that it's a great discussion. So I find the most useful thing is in these scenarios of something that looks like this, but there's a clinical history of breast cancer, right? Or something
Yes.
like that, right? And then you do a GATA, and then these are all GATA positive and TTF negative, right?
Correct.
And so
Absolutely.
so I think it's putting all those pieces together, but in something that, quacks like a lung, like it looks like a lung, it's
Yes.
probably lung cancer, right? So
It's probably a lot. So I think for me, the two main things are history is absolutely
yeah,
super important here. And second is just because something is TTF negative does not mean that it is
yeah.
not a lung cancer.
It's great. Okay, so let's move over to things that look kind of squamous. So you have something like this, and there's some clear squamous differentiation on histology that's got like keratinization or intercellular bridges. Maybe that's not the most specific, but something that has keratinization. What do you think about that scenario?
Yeah, this is the most clear-cut squamous possible. So something that has keratinization. In that case, I feel very happy to call it squamous on H&E alone. So I don't do any immunostains for subtyping this, so to tell adeno versus squamous. And for the question of site of origin, there's no point of doing aminos anyways, because all squamous have the same immunophenotype. The only exception here, Matt, is that if there is a um, if there's a P16 slash HPV
Yeah,
positive primary in the cervix or in the oropharynx, there I think you can do. It's very helpful to do a. Uh, I think HPV is the best thing to do here. High risk HPV,
yeah,
CISH, and there you really can tell because lung is never positive for high risk HPV, at least in my experience. Never, and in the publications that I've seen, so there is a good rationale to do immunohistochemistry. Otherwise, there is no rationale here to do. And I mean, for me at least.
yeah. I agree with you, and I just wanted to say I think the CISH for HPV is actually better than P16 because
Yes,
the P16 is non-specific and you can get it in other scenarios,
absolutely.
including a subset of non-HPV related cancers. So
Correct.
I just caution people with using P16 as a marker in this
Yeah.
scenario, right?
And as usual, Dr. Katzenstein was, far ahead looking at this problem. She realized many years back. Actually, the first author on that paper is my wife, Erica
Nice.
Dockstader. So she did this paper with Dr. Katzenstein where they looked at exactly this question: can lung carcinomas be P16 positive? And in that paper, from what I remember, almost a third of lung cancers were P16 positive,
Wow.
but none of them were high risk HPV positive.
Yeah.
So if you use P16 and say, whenever P16 is positive, I'll call it a met from somewhere else, you will go wrong
You
because
won't.
lung cancers can be P16 positive,
That's
primary lung
great.
squamous.
Okay, so what about this scenario where we don't have clear glandular differentiation or squamous differentiation, and we're kind of in a non-small cell NOS type of category on a small biopsy?
Yeah,
What do
this
you
is
think?
the best reason to do immunohistochemistry. So this is the sitting where immunohistochemistry I think is most helpful in a in what is appears to be a lung cancer. So
Yeah,
here I do TTF1 and P40. I think that is enough to subtype most of these cases. So if they're TTF positive, they're adeno. If they're P40 positive, they're squamous. And some cases will be negative for TTF and P40. And those cases might need a little more immunohistochemistry. So you might want to do a pan-keratin just to make sure that it's carcinoma. Sometimes you'll need to do a SOX10. I've seen some cases that look like this that turn out rarely to be angiosarcoma, so you might
mm,
need an ERG. And if even a keratin is negative and all these things are negative, you might want to explore the possibility of a smart K4
yes,
UT. But I think most cases, the vast majority of such cases are solved by just doing a TTF1 and P40.
P40. I think for the audience here, it's maybe some of the more junior listeners, maybe we should discuss P63 versus P40 and why you may want to choose one or the other.
Yeah, so the reason so P63 and P40 are both squamous markers, both show nuclear positivity, both are excellent, and both are essentially 100% sensitive. So they do stain all squamous cell carcinomas, most of them strongly and diffusely. So they're great in terms of sensitivity. What P40 is much better at is specificity in the sense that it does not stain adenocarcinomas at the same rate that that P63 does. So P63 stains about 30% of adenocarcinomas of the lung, usually focal and weak, but that rate is much lower with P40. So the chances that you will have a difficulty in interpretation are lower with P40 than with P63. So that's why it's just easier to use
Yeah,
P40 if you have it than P63.
agree. And then maybe we chat a little bit about clones of TTF1 in this case as well.
Yeah, great
A-
topic, man.
and
Yeah.
and about which one and why they're different and what we should think of there.
Yeah. So the clones, the main clones really, I think, are SPT24 and 8G7G3/1. So SPT24, which is the sensitive clone, and 8G7G3/1, which is the
Ooh,
specific
I
clone.
always forget the exact name. 8G7.
G7G3 slash 1,
G3, right, 8G, uh,
G7,
G7,
yeah, and then G3
G3. Thanks.
slash 1. Yeah, and then you want to get rid of one of the G's in the
Geez,
G.
too many G's. There we go. Thank you.
Too many G's. Yeah.
Yeah.
So, I think people are inherently attracted to use a sensitive clone, but the problem with the sensitive clone, it is too sensitive so that it will stain things that you don't want to stain with TTF1, which is squamous cell carcinomas, other primaries of other sites like GI, breast, and other things. So the sensitive clone actually cannot be trusted. That's the problem with the sensitive clone. So it picks up a lot of adenocarcinomas, maybe higher than the specific clone, but it cannot be trusted when you're trying to use this for as in a setting where its specificity is very, very important. So for subtyping, for determining site of origin, I don't think the SPT24 is as good as the 8G7G3/1. So that's why we use the 8G7G3/1. When it gives you a result, you can trust it. When it tells you that TTF1 is positive, you can be sure that this is an adenocarcinoma or squamous. When you're trying to do lung versus GI, and it stains, you know that it's actually indicating lung versus GI. So that's why I use this. Matt, what do you use in your?
Yeah, so my lab actually has SPT24, which I completely agree with you. It has some pitfalls with it, right? You can overcall it. I think it's okay as long as you know your tool, right? In a way, right? So I just
Right.
know that mine is oversensitive and not always specific, and so um, I can't rule out that it's just staining something else. So I always use it in context of other stains, and just cognizant of that. In some ways, the ideal thing is actually having both, because I think they both can help you and help you ask different questions, right? If you have a poorly differentiated thing that's not staining for anything, and you get some SPT24, well, then it's probably lung, right?
Right.
Whereas if you got something that it is staining with 8G7 7G3/1, then you're more likely to believe it is lung. So I think the in some ways the ideal thing is to have both, because I think they're helpful tools in their own way. Definitely. So I think that was good for non-small cell, and then kind of
Yeah.
let's move into this where we're into the neuroendocrine world, right? So let's kind of start with, we get a small biopsy of this kind of crushed, kind of blue thing, that maybe you can see a little bit of, granular nuclei and maybe some molding, but it's kind of really crushed.
Yeah.
What do you think about in this scenario?
I've changed my thought about this over the years, Matt, a little bit. I mean, a little bit, yeah. So what has changed is I feel now that if the clinical setting and morphology is perfect, right? So I'll tell you what that means. So an older person, they come in with hyponatremia and SIDH. They're a big time smoker. They have a big hilar lung mass, and it's, mets to the lymph nodes, sometimes to the brain and adrenal. In that setting, if you have morphology like this, I don't think that you don't necessarily need to do immunohistochemistry. And especially if you're in a resource limited setting, I think that's even a more reason not to do immunohistochemistry here, because the yield of finding something other than small cell is extraordinarily low. It's very low. Now, having said that, if the morphology is a little odd and you're not sure that that's small cell, and let's say a poorly differentiated squamous might be in your differential, that's a reason to do
Mhm.
immunohistochemistry. And so the things I do are keratin, just a pan keratin like an A1, A3. I do a synaptophysin, chromogranin, and INSM1. So three neuroendocrine markers, which is I think a bit of overkill. And then a TTF1. And I think the most important thing is a
Yeah.
P40 to rule out as squamous, which is really the only game changer. And nowadays I've started doing an RB1,
Oh,
which
nice.
is a loss of RB1 sometimes helps you when there's a disagreement about morphology. And I feel my colleagues and me both are more likely to call something small cell if RB1 is lost and the morphology is borderline. So yeah, this is my panel, Matt. What about you?
Same. I put key 67 on it as well. Especially in these scenarios where it's kind of crushed, and I just always worry that I'm looking at a crushed carcinoid, especially in a small biopsy. And so um, to me, that's just kind of a safety thing of there. And Also, depending on where you practice, some clinicians really want the Ki67 index, even though in the lung
Yeah.
it doesn't have the same role as in other neuroendocrine tumors. But my
Do you have
clinicians
any rule of thumb, Matt, for how much Ki67 you need to
call,
support this? Everything should be positive.
well, you like to see the 90 to 100%, right? That makes you feel a lot better.
Yeah,
But they can be variable. Like the literature says that they can have a variable amount. But
yeah.
if it
So what
starts
do you
being
do in a case like that? Like something that looks like small cell, but the Ki67 is, maybe 50% or so. What do you do with a case like that?
50 is okay, but once you start getting below that, it's very worrisome, and then you want to be making sure you're not missing something else. Even 50, you just probably want to take a second glance, right, and make sure you're not overcalling a carcinoma or like a non-neuroendocrine carcinoma, right? Because those tend to have a lower incidence, or
Yeah,
and sometimes the large cell ones can have a lower Ki67 as well. So it gives me pause and makes me the diagnosis is morphologic, but I
yeah,
find the Ki67 helps, right? Especially if you're not seeing mitotic activity or necrosis and you have
yeah,
a low Ki67, you should definitely rethink your diagnosis of small cell.
yeah, yeah.
I don't know. Did you
Good point.
you don't do Ki67 in these?
I don't, Matt. I
Yeah.
don't for the reason that I mentioned. Like in the borderline cases, I feel I have to go back to morphology anyways.
Yeah.
But your point about if you don't see mitosis and necrosis is very, very good point.
Yeah.
Actually, you should doubt a diagnosis of small cell if you cannot prove that it is high grade on
Yeah.
morphology. And I think that's a good reason to use Ki67. I just find that I usually can do it on morphology, and so I
Yeah.
don't. I never call something small cell unless I can be sure on morphology that it is high grade. I would rather just call it neuroendocrine neoplasm C comment
Yeah.
than yeah. So
That makes sense. So what about a lower grade neuroendocrine tumor on a biopsy? Is that
yeah,
something in the carcinoid spectrum?
this is
Um,
also a good. I think this is also not a clear-cut situation. I think if like the small cell, if your clinical setting and morphology is perfect, again the yield of immuno is so low. So in a case that has great morphology like this, it's a youngish person, never smoker, has a solitary small nodule. I think it's very, very likely to be carcinoid, and you don't need to necessarily do any stains. And I like on lobectomies, I don't do the
yeah.
stains. But in a small biopsy where the morphology is a bit iffy and you're not sure, I think synaptophysin, chromogranin, if you have INSM1, that, maybe a keratin, TTF1. So almost the same markers. Maybe you don't need a P40 and RB1, but
Yeah.
the rest are helpful because these are keratin positive. Synaptochromo INSM1 are invariably positive. TTF1 is either negative or weakly patchy positive. So all of that helps to uh, confirm. And some people, also consider paraganglioma in the differential.
Yeah.
And so for them, keratin is also helpful.
Yeah, and I think the TTF1 is an important thing because I think a lot of people think that these should be positive and get worried when they're negative if that is just a metastatic neuroendocrine tumor. But as you
Yeah,
mentioned, they're often negative or weakly positive in
great
these
point.
cases.
What's your panel, Matt? Do you do IHC always, and what do you do?
I have a similar panel. I don't always do it depending on the scenario, but the when I do it, I don't have INSM1, so
Yeah.
the actually I'd love your thoughts on that. So when do you find INSM1 helps? Like I find Synapto is the most sensitive, Chromo is a little bit more specific, and and how does INSM1 add to that panel?
Yeah, I think if you have Synapto and Chromo, I don't think INSM1 necessarily helps you that much, in I because it's sort of intermediate between Synapto and Chromo in terms of sensitivity, slightly less sensitive than Synapto and slightly more specific than Synapto. So it's and not as specific as Chromo. So I think it does not help you much. It just gives you a third
Yeah,
marker, which sometimes is helpful in a difficult case, where let's say Synapto and Chromo are both negative and INSM1 is strongly positive. That
mm,
doesn't happen often. It's really not a common thing at all. But there I would say that it might be helpful. But your point is well taken. If that's the point you're trying to make,
yeah,
Matt,
it is. Yeah.
it doesn't add much to
Oh,
Synapto and Chromo.
great. And then just to finish the neuroendocrine thing, so what if you have more of a like not a small cell morphology, but we have more of a large cell morphology with kind of some organoid architecture. These ones I actually find kind of challenging, right? Especially on a
Yes.
small biopsy. I think it's easy to say, oh, this is just a solid adenocarcinoma.
Yes.
And I find that this is actually a bit of a diagnostic pitfall. If you just
Yes.
go back to our initial thing here, where you're in this non-small cell category, and you're not,
Right.
and the question of when to put in neuroendocrine markers into a
Yes.
panel, I think is a challenging one. And I'd love to hear your thoughts on that, Sanjay. When do you?
You're right, Matt. Super challenging. I think this is difficult no matter what the morphology
Yeah.
is. And for every lung case, you have to think of that. Will it help to add a neuroendocrine marker? And I
Mm,
think the question to ask yourself is, will you believe the neuroendocrine markers when they are positive?
yeah.
So in a case like you showed, the first adenocarcinoma, I'm not going to believe it even if it's positive. So in that kind of a case, there's zero need to do not the non-small cell, but the adenocarcinoma,
Oh, I
the
see. Yeah.
clear-cut adenocarcinoma.
Definitely. Yep.
So like, yeah, so in a case like this, there is zero
Yeah.
need to
Agree.
do. So that I think you should never do it. In a clear-cut keratinizing squamous, zero need to do it, and you should never do it. It will
Agree.
get you into trouble because it will stain focally positive once in a while and is of no use. I think where in the next case, there you have to ask yourself, you have to ask yourself, will I believe it if it's positive? So in cases that have absolutely no neuroendocrine, a hint of neuroendocrine morphology, like this one, where there's no granular chromatin, there's nothing organoid, there's no rosette-like formation, there's no palisading at the periphery. I also use lots of necrosis or, very subtle things.
Hmm.
I don't do immunohistochemistry in a case like this, but in
Yeah.
the next one that you showed, the last one, I think there's a little peripheral palisading, there's a little granular chromatin. You
Yeah.
can see high mitotic activity. There might have been necrosis elsewhere. There, I think, yeah, this could be a high-grade neuroendocrine carcinoma,
Yeah.
and there it's reasonable to do immunostains. And I think here the biggest problem is even after your immunostains, sometimes you're still struggling with whether this is small
Yeah.
cell or large cell neuroendocrine or adenocarcinoma, and that is not an easy thing
I agree.
to figure out even with immunostains, I feel,
Especially in a small biopsy, right?
especially
And
on a small biopsy. No matter what you do, it can still be challenging because it's at the end of the day a morphologic call, whether it's
mm,
small cell or non-small cell. Immunohistochemistry overlaps greatly between
yeah.
large cell neuroendocrine and small cell. And now we know that even between adeno and large cell neuroendocrine, immunohistochemistry can overlap greatly.
Yeah.
You can get NAPSIN positivity, KRAS mutations, that kind of thing
Yeah.
in what people call large cell neuroendocrine carcinoma.
Do you find napsin helps in this scenario?
I used to, man, like I used to, uh, whenever napsin was positive, I would just call it adenocarcinoma.
Okay.
But now there's this publication from Memorial Sloan Kettering
Okay.
where they call things large cell neuroendocrine carcinoma. And even if napsin is positive and KRAS positive, they still call it large cell neuroendocrine carcinoma,
Okay.
which is
Well.
really, it really makes things very difficult for everybody, I think, to do that.
Okay. Well.
But I acknowledge that you can have a lot of neuroendocrine
Yeah.
staining in something that is. So I've seen this. Actually, I just yesterday saw a case like this
Mm.
where somebody had an synaptochromo INSM1 strongly diffusely positive, looked a bit neuroendocrine, and was napsin positive.
Oh my
So
God.
what is that? Is that a large cell neuroendocrine or is that
I don't think we know.
adenocarcinoma? Yeah, it's just a difficult issue. I
That's
have no
tough.
easy answers on that. What are your thoughts, Matt? What do you think about that kind of a case where it has both?
Yeah, I think ultimately there's some you just don't know, right?
Yeah, yeah,
And I guess my approach on the small biopsy scenario is just to be a bit conservative and just in a comment outline my uncertainty of what it could be,
yeah,
and sometimes these things are more clear on the resection, right?
yes,
Right, that sometimes if there's a clear adenocarcinoma component, then it's maybe just an adenocarcinoma with some neuroendocrine differentiation, or maybe
yes.
there's other areas that are more classic large cell, and sometimes that helps. But that's kind
Yeah,
of what I do.
totally agree. Totally agree. This is great advice you gave just now, Matt,
Yeah,
about on a biopsy. If you're not 100% sure, just step back
yeah,
to the one less conservative, call it carcinoma or carcinoma with
yeah,
neuroendocrine features or high grade, something that covers both entities, and
yeah,
then outline your differential in the. I think that is okay if you don't do it all the time. If you do it for an occasional case, it's very much a reasonable approach.
yeah.
Yeah.
Great. So now let's move on to like something like this, something that's kind of spindly. And let's say in a scenario, this patient doesn't have a history of a sarcoma or anything. This is an isolated mass
Yeah,
in the lung, in
yeah,
like a smoker, right? So
yeah.
um,
This is
the
a good this is a good question. It shows up in consult practice all the time.
yeah.
Spindle cell lesions of the lung. I think the first thing that I try to think is this just a carcinoid tumor that's spindly? So I look
Mm,
for whether this is just a low grade neuroendocrine neoplasm. Does it have granular chromatin? Many people don't realize that carcinoid tumors can be very spindly looking, very,
mm-hmm, yeah.
very elongated cells. So if it's very granular and low grade looking and has granular chromatin, I might try neuroendocrine markers on this, just a
Yeah.
synaptochromo. If it is high grade and clearly malignant, which
Mm,
I'm not sure I can tell from this picture, but if it is high grade and clearly malignant, then I do consider. Now it's really comes down to two things for me. Is this a sarcomatoid carcinoma or a sarcomatoid mesothelioma?
great.
And both of them should be keratin positive. So a pan keratin stain is super helpful in
Yeah.
this situation because it narrows down the differential to sarcomatoid meso and sarcomatoid carcinoma. And in that differential, I think the by far the most important thing is where is the mass.
Yeah.
If the mass is a parenchymal lung mass, I don't think any immunostain overrides that. I don't, in my, this is my personal opinion. I don't think
Mm,
any degree of GATA3 staining or WT1, anything does not override a parenchymal, intraparenchymal lung mass. On the other hand, if it is pleural, if this kind of a mass has multiple pleural lung nodules and a, appropriate clinical setting, an elderly man, unilateral,
mm-hmm,
I think no immunostain, other than TTF1 maybe, no other immunostain will change my mind that this is likely to be a sarcomatoid mesothelioma in that setting. So I think if it's keratin positive, your differential is between two things. And in those two, I feel that where the mass is located is the most important thing. Now, if keratins are negative, then you have to think of sarcoma.
yeah.
And what I do is show it to our sarcoma people, but don't do a Vimentin. That's not your that is not your friend here.
No,
What do you think,
definitely.
Matt? What's your approach? I'm really curious to hear how you
Yeah,
approach
yeah.
this.
So I think a keratin is the most important first stain I do in these. And it's not just to me, it's not just about is it positive or negative. It's more about how it's positive.
Yes.
So in something that looks really spindly like this, if it's really diffusely and strongly keratin positive, then that to me is a bit of a soft sign that this might be more like a meso, a sarcomatoid meso, than a carcinoma. Because I find that the sarcomatoid mesos hang on to their keratin to the very bitter end. And whereas a sarcomatoid carcinoma, you more expect them to be a little bit more patchy or focal keratin staining.
Hmm.
And I always do at least two keratins on these.
Okay.
Either an A1, A3, or I have a pan keratin that's got an A1, A3 and a cam in it, so it kind of
Great.
it covers me from there. And
Yeah.
then that's kind
Actually,
of
this is, can I interrupt, Matt?
yeah, sure,
One
please.
point I want to make here because you touched on a great thing. Is one of the most frequent errors I see in consult practice is people do their CK7 and
Yeah.
CK20 and they do not include a pankeratin. And I just, that boggles my mind. Why would you not have a pankeratin stain in your department? I mean, if you have spent the money to get a CK7 and a CK20, just get a pankeratin
Yeah.
of any kind. It is so helpful to do. So please do a pankeratin stain
Yeah.
on your poorly diff cases. Yeah.
I almost actually never run CK720
Yeah,
because
me neither.
I find that they like you almost always just get a CK7 OMA, right? Where it's CK7 positive and
Yes.
CK20 negative, and you give that same laundry list of all the things that it can get, right? And
100% agree. 100%.
anyways, but yeah, so the keratin first, and then where that goes, then completely agree with where you were saying is then do you go down the meso or carcinoma, or is this a potential sarcoma scenario, right?
Yeah.
Um, I do try the meso and carcinoma stains, but
Yeah.
in something
Me
spindly
too.
like this,
Me too.
they often don't work. I try the GATA. I do find the GATA if it's diffuse and strong in all the cells that's helpful. It's not definite, but I've
Yeah.
had that has helped me in the past. Like,
I've heard other people say that too, that they
yeah,
find the GATA helpful.
yeah, but you have to be careful though because you get a lot of non-specific staining, and so the informative GATA staining is like every cell is positive.
Yes.
Uh,
And again, Matt, I mean, I'll put this scenario to you. Let's say you have this kind of a tumor,
yeah,
clearly malignant. Uh,
Yeah.
pan-keratin diffusely positive. And then I tell you the mass is a solitary 7 centimeter intraparenchymal lung mass.
Yeah, then yeah, it's
Will you
bullshit.
call it meso
No.
with diffuse gata? No, right? So the clinical setting can override even the most compelling immunostain thing here because it's so important. It's so
Yeah.
important where it is and
It,
what the imaging features are.
yeah, maybe I just have bad luck, but I find a lot of cases they're like they're somewhere in the middle, right? It's like, oh, and
Yes,
it's
yes.
involving the pleura, this big mass, right? It's like and
True,
so
true. Same here.
and so you're like, okay, well, it doesn't really help me. But
Yeah,
yeah.
and there are many cases like this that don't have a clear-cut answer, even after the immunostains, even after you know where it is, you don't know for sure.
And sometimes you don't know, especially small biopsy. And I often will diagnose things as malignant sarcomatoid neoplasm, see
Me
comment.
too. Me too.
And sometimes I say like, look, I don't know if this is carcinoma, meso, or sarcoma.
Yeah,
And I think that that is very reasonable, especially on a small biopsy, as long as you're doing your best to try and solve it, but sometimes you can't, right?
totally agree. And same with me, Matt.
Yeah.
Same.
Great. Okay, so this has been good. Just I think we're getting to the end of time. So let's keep just last scenario here. What if we have something that looks like this? I just
Ooh,
yeah, so I don't know, what would you do in this scenario? Get this like kind of more rhabdoid or plasmacytoid cells or a little bit more discohesive as kind of a
yes.
core biopsy. Would you
So this is actually a great fun to work up these cases because there is a nice differential here,
Mhm.
which mostly I think works out. If you think of, so I think first thing to think about is a carcinoma. So a poorly
Yeah.
differentiated non-small cell lung carcinoma can look like this. So if it's TTF1 positive, is adenocarcinoma. This just happened last week for me.
Mhm.
Poorly differentiated adenocarcinoma can look like this. So TTF1, pan-keratin, of course. Um, you want to do a P40, in case your TTF is negative and you're going down that line. Then your question will be if your TTF1 and P40 are negative and pankeratin only is positive, then it might be just a poorly differentiated non-small
Yeah.
cell carcinoma. I think that's reasonable. Then if your pankeratin is negative or even weakly focally positive, you have to then consider melanoma and
Yeah.
angiosarcoma. I think
Great.
both of them are very, very. I've seen cases that look exactly like this and then turn out to be either melanoma or angiosarcoma. So SOX10 and ERG are my favorite, but you can
Okay.
use the other stains in this setting as well.
Do you
Um,
do you start with just the one or do you
I do
do
only SOX10. Yeah,
okay.
SOX10 is by far the best. But then, if those two are also negative, then I think then it becomes much wider.
Yeah.
How much you want to work up is very much a matter of personal preference. You can do many other things. You can do INI1, you can do the other melanoma markers, you can do BRAF, you can do molecular tests. It's unlimited how far you can go with this.
Yeah.
But I think these five stains that you have listed are really great to start with. What do you think, Matt?
Agree completely. And then
Oh,
so
sorry, I missed one. I missed one. The BRG1,
yeah,
Smart
BRG
K4.
one.
Yeah, of course,
I
that's a big one. Very high yield stain in this setting. Very
agree.
high.
Yeah. Yeah. I in this scenario, I don't do that right off the bat.
Yeah.
I kind of what I actually start with is like I start with a CK pan,
Yeah.
SOX 10. I usually start with that just to figure out like 'cause this could very much be melanoma, right?
Yes. Yes.
As long as there's not an urgency to sign it out the next day, like if I have a day or two to get this out, especially if
Yeah.
I have limited tissue, sometimes I'll go slow on these and just
Very reasonable. Yeah.
figure out a lineage first. Because if your pan keratin's negative, I don't think there's a role for TTF1 or P40, right?
No, and yeah, exactly. And actually the reverse is true also. You don't want to do the BRG1 up front because then you'll
Yeah,
get SMARCA4 deficient carcinomas and you'll be confused. I think you want to do the BRG1 only if your keratin is
yeah.
negative or only, equivocal.
Okay.
That's when you want to do the BRG1.
And so in this scenario, say the SOX 10 was positive, would you call it melanoma on that, or would you do more stains, or
Depends. So, let's say there's a history and
yeah,
the morphology is great. I do call it melanoma just
yeah,
with the SOX10. If I'm there's no history and I want to be, I usually do the other
yeah,
markers as well. So I'll do an HMB45 MART1, yeah. So mostly do all three stains.
yeah? It's the
Uh,
same for me.
and there is, of course, there's that very rare thing where even SOX10 can be negative, and you can have just, those
Yeah,
poorly undifferentiated melanomas where there's a history of melanoma or the mutation is positive. So it can be melanoma even without the SOX10. People should know that.
Definitely. And in this case, is melanoma, and I think it's just important to remember that these things that could have a borderline morphology of a carcinoma can actually just never forget melanoma in your differential.
Yeah, this is a great question to bring up because it comes up quite a lot. And
Yeah,
actually, one more thing to remember in this setting is metastatic RCC can look
yeah,
exactly like this. So Paxate is a good one to consider if you have a history, if there's multiple nodules, you might want to include it in your panel, Paxate.
it's great. Well, so I think this was a good discussion of different approach to IHC and small biopsies. Any last points you wanted to give to our listeners, Sanjay, before we
So
close?
this is terrific, Matt. Thank you so much for having the idea to do this. It's such a great idea.
Yeah, no problem.
I think I'm trying to think of what else comes up in biopsies where immunohistochemistry is a I think you've covered everything. I think the one question you can ask is, what do you do if a patient has a history of a carcinoma somewhere else? I
Yeah,
think you covered that with your colorectal met, but the same could be true for, let's say, renal cell carcinoma,
yeah.
where you have a clear cell carcinoma in a lung and you have a history of RCC. You can ask the same question. Do you need to do immunohistochemistry or not? I think it's reasonable to do it. Just, a Paxate and a TTF1.
Mm.
That's a good setting to just for confirmatory immunohistochemistry.
Here's a question for you, Sanjay. What do you do if someone's got a urothelial history and they have a
Oh,
kind of
yes. Great,
and
great
and,
question.
and they have like a squamoid type lesion that
Yes, this is a
what
great question. So I find that immunohistochemistry can be helpful there to tell. So we are trying to say, is this squamous cell carcinoma or a urothelial carcinoma, both of which can be positive for P63, P40, and CK56. So and also very important to remember GATA3. So
yes,
GATA3 can be positive both in primary squamous lung, this is well documented, and in metastatic urothelial. So I think the most helpful thing is if you do that panel and you have a P40 positive, diffuse positive, and GATA3 negative case, then you
yes,
can be pretty certain that this is primary lung.
great,
But if you have any other result, it's inconclusive. So if you have GATA3 staining, um, let's say you have GATA3 positive but P40 negative, that might be useful, but I don't think that happens often.
no.
So the only useful staining situation there is P40 positive, GATA3 negative. The rest, I think there's way too much overlap to be 100% certainty there.
And you're just doing that in cases where patients have a history of urothelial
There's a
carcinoma.
history, yeah.
Yeah,
Otherwise, why would you do a GATA3 in a clear-cut squamous of the lung?
yeah, no, I do the same, but
Yeah.
I guess there is a risk that it could be a met. But I think this is where it's a collaborative scenario, right?
Yes,
And I never say a squamous cell carcinoma is a lung primary because
exactly.
I can never know. It's just a squamous cell carcinoma, and
Yes, it's
it
the
could.
same philosophy as in adenocarcinoma of the lung. The determination of a lung primary is a collaborative
Mm,
clinical pathologic effort. So you should not feel the pressure to commit. And if the clinician asks you, is this a met from somewhere else? You ask them from where? From where would it be met from? Do you have a
yeah,
primary somewhere else?
yeah,
I ask them, and that happens in adenocarcinomas too.
yeah.
Sometimes, very rarely a clinician has asked me because I don't do the stains, they say, well, could it be a met from somewhere else? I ask them, where would be a met from? And
Yeah,
then they go silent, because there's no clinical evidence of
yeah,
anything.
exactly. Well, that's great. I think we covered some really good, hopefully useful points for the listeners. And thanks everyone again for joining us. And hope everyone has a wonderful day.
Thank you so much, Matt. Brilliant idea as always.
Thanks.
On a small lung biopsy with tissue that's so fine, we've got to be judicious in how we draw the line. Clinical history, radiology too, they guide our hands, tell us what to do. We've got to know when to stain them, know when to skip them, know when to walk away, and know when to test. You never count your markers when the tissue's on the table. There'll be time enough for testing when the diagnosis rests. For adenocarcinoma, when morphology's clear, no need for immunostains, we hold those tests dear. But if there's a history, or the cells look strange, TTF1 and PAC help us make the change. You've got to know when to stain them, know when to skip them, know when to walk away, and know when to test. You never count your markers when the tissue's on the table. There'll be time enough for testing when the diagnosis rests. For the salivary carcinoma, TTF1's no friend. CDX2 and PAC help us comprehend. For squamous cell carcinoma, if keratin's on show, we can call it on H&E, no need to go below. You've got to know when to stain them, know when to skip them, know when to walk away, and know when to test. You never count your markers when the tissue's on the table. There'll be time enough for testing when the diagnosis rests. For those non-small cells, NOS might be the call. TTF1, P40, these two cover all. And if colorectal's lurking with nodules far and wide, just sign it out on H&E, let morphology be your guide. You've got to know when to stain them, know when to skip them, know when to walk away, and know when to test. You never count your markers when the tissue's on the table. There'll be time enough for testing when the diagnosis rests. Neuroendocrine tumors, poorly differentiated and tough. We'll add a few more markers when the going gets rough. Pansynaptome and chromogranin too. But keep an eye on morphology, let it guide you through. You've got to know when to stain them, know when to skip them, know when to walk away, and know when to test. You never count your markers when the tissue's on the table. There'll be time enough for testing when the diagnosis rests. For spindle cell neoplasms, PAC sets the stage. If positive at TTF1, let the stains engage. Negative for PAC, look beyond the usual track. Sarcoma or melanoma, it's time to take it back. You've got to know when to stain them, know when to skip them, know when to walk away, and know when to test. You never count your markers when the tissue's on the table. There'll be time enough for testing when the diagnosis rests. Remember, in small biopsies, tissue's a precious prize. Molecular testing might be the key.